Welcome to the peel technique. How do we get from here? And there are four critically important things to notice on this slide. So how do we get from here to here? How do we get from a 1-week-old baby with a severe maxillary anterior lip tie, with Epstein pearls on a very highly vaulted palate, with a tongue that cannot rise anywhere near the roof of the mouth, making the baby unable to latch onto mommy's nipple and nurse, with a typical heart-shaped appearance of a tongue that is tied down in the center by a tight frenum. To here, with a beautiful conservative tongue tie release, with the tongue rising to the floor of the mouth, with a tiny conservative little scar from the procedure. This photo was taken 5 seconds post-op. How do we get from here Notice the baby's suck. The baby is sucking on my finger, which is coated in mommy's breast milk. The baby cannot maintain a suck. The baby is coming off of my finger like the baby comes off mommy's nipple. Take a look at the huge nursing blister on the upper lip. Take a look at the masseters not working together in a coordinated fashion. So how do we get from here with a poor suck to here? Notice you cannot see the lip blister anymore because the baby is flanging over my finger much more successfully because the lip tie has been released. Notice the baby is not coming off of my finger, not coming off of mommy's nipple, being able to suck more efficiently and effectively, and notice the masseters working in tandem. How do we get from here? Notice no peristalsis of the tongue, no extension of the tongue out of the mouth, no elevation of the tongue to the roof of the mouth, no lateralization of the tongue. So how do we get from here to here? Beautiful elevation of the tongue to the roof of the mouth. The baby can now grasp onto mommy's nipple and nurse successfully, and you see the immediate post-op little scar on the base of the tongue from the tongue tie release. No bleeding, no swelling, beautiful result. The peel technique. Peristalsis, elevation, extension, lateralization. The 4 movements the tongue must make in order to achieve ideal breastfeeding. When the baby cannot achieve peristalsis, elevation, extension, lateralization, you have a baby that will fail to thrive, a baby unable to breastfeed successfully, a baby that will be breastfeeding every 2 to 3 hours unsuccessfully, a baby that will be chomping down on mommy's nipples. Mommy will end up with sore nipples, cracked nipples, bloody nipples, engorgement, and mastitis. Remember peel, peristalsis, extension, elevation, lateralization. There is none of that here on this slide. You see the typical anterior tongue tie from the tip of the tongue to the mandibular ridge. The tongue cannot make any of the movements necessary for successful breastfeeding. Right between the 2 arrows. This is a typical posterior tongue tie, from the ventral surface of the tongue to the floor of the mouth. It can sometimes attach all the way down to the genioglossus muscle, and in severe cases can impact the position of the hyoid bone. Sometimes these posterior tongue ties are difficult to visualize, such as this. Between the two arrows. Sometimes these posterior tongue ties are quite obvious, a nice thick band of tissue. Note the typical heart-shaped presentation of this tongue, tied down in the center because of the tongue tie, but able to lift up at the sides. Critical diagnostic question to ask mommy. When she breastfeeds the baby, does she hear a clicking sound during her breastfeeding? What is that clicking sound? As the tongue attempts to rise to capture mommy's nipple, the frenum pulls the tongue right back down, and that clicking is the frenum pulling the tongue back down so that the tongue cannot grab onto mommy's nipple and nurse correctly. One of dozens of diagnostic questions and criteria before you decide if this is a candidate for a tongue tie release. Stingray effect. The tongue is up at the corners but unable to lift in the center. Notice how the tongue looks cup-shaped, typical of a tongue-tied baby unable to lift. The baby comes into your clinic, into your office, and you notice there's a white patch on the tongue. What is it? Is it thrush? Well, that's a possibility. 99% of the time, this is not thrush. This is undigested milk on the dorsum of the tongue due to poor peristalsis. As a result of the submucosal tongue tie and lack of peristalsis, that last bolus of food sits on the tongue, unable to be digested, unable to go down into the esophagus and into the digestive system. How do we know it's milk, not thrush? Simple. Milk wipes off quite easily with a wet piece of 2x2 gauze or a wet cotton roll. Thrush does not. Remember peel. Remember there's no peristalsis here. White patches of milk showing that the baby cannot peristalse their tongue. We'll be giving a 2-day comprehensive assessment treatment of tongue-tied babies right here at the New Jersey Health Professionals Development Institute, Friday and Saturday, June 18th and 19th. These courses always sell out, so please make sure you register early. If you cannot make that course, we have it also scheduled for Friday and Saturday, November 5th and 6th. And if you have any questions, please contact Tracy at the New Jersey Health Professionals Development Institute, or if you have more specific questions and want to talk to me, my name is Bob Conversar. I'm a diplomate of the American Board of Laser Surgery. I practice in Manhattan. You can contact me by email at laserbobdds@gmail.com. A simple email. I use a laser. My name is Bob, and I'm a DDS. laserbobdds@gmail.com. You can check what laser courses I have and tongue-tie courses at fullspectrumseminars.com. But a better way to look is just come to the New Jersey Health Professionals Development Institute website, and you can see all of the courses we have scheduled at the Laser Institute at the NJHPDI. I hope to see you soon. Any questions, just email me. Thank you.